to Lisa.
Good afternoon, everyone. Like Brita said, I'm Lisa Schwanke, and I work with technical assistance, and I also do quality improvement for Hope Haven up in Rock Valley. So we're going to get started today. Once Brita shows me how to work this thing. So, imagine that, you have to push an arrow key. So we're going to start by talking about why we do documentation. Obviously, we do documentation to prove implementation of the service plan. It's critical that, especially as MCOs are coming on board, that we can show them that we're implementing the service plan, that the things listed in the service plan are necessary to support the person we're providing services to. We also use it to document progress or lack of progress. As you know, there's rules in Chapter 83 and Chapter 90 that says if a service plan isn't working for someone, it should be changed. Your documentation is going to tell you when you need to go back to the team and say, we need to change something for this person. You should always document changes in the person's condition. So if you have someone who has always slept through the night and suddenly they're not sleeping through the night, you're going to want to make sure that you document that just so that you can track that and see if that's a random thing. Maybe the person wasn't feeling well one night, or if it's a pattern of things, and it may mean that you need to take them to the doctor. Obviously, in my world as a quality improvement person for my agency, I look at documentation to assure that we can prevent recoupment. So I'm looking at things that we'll talk about later in the day. It's also for communication. I don't know how many of you use your documentation for that, but I know at our agency, we several of our staff, especially our part-time staff, can look back the last few days of the documentation and really get a handle on what's going on with the person, and knowing what the specific supports the person may need is going on at that moment. And then obviously to see what's working and what is not working as you support people. Once finished, it's important to understand that documentation becomes a legal document, and it needs to be treated as a legal document. Documentation is not a place where you want to be cute and see if anybody's reading it. So you're not going to want to talk about Mickey Mouse or the weather. You're going to want to be very serious with your documentation and very factual. Documentation is used to support billing. It can be analyzed for what's working and what's not working. Once documentation is finished, it doesn't go to that little black hole and never looked at again. If you're financially audited, the auditor is going to be looking for the documentation to support each unit that was billed. It's going to be looking at whether in a financial, it's going to be looked by the interdisciplinary team and financial payers to review service needs and to assure that any needs that are listed in the assessment are either being worked on, or that at least the needs that you're working for are in the assessment. And it also can be reviewed by internal and external investigators. I think it's important to remember that as you're documenting the services you provided. You're also documenting that while you were working with that person, they were safe and their needs were being met. That could be very critical if that ever comes into question. When you're documenting and when you're providing services, it's very important that the services are provided are based on an assessed need, are part of the person's service plan, and are within the scope of the service you're providing. So it's important that you understand what that scope of service is. That's going to tell you what services you can provide as part of the services, and more importantly, what services you cannot provide as part of the service. If you do something that is not part of the service, you cannot bill for that. I think sometimes I know that people have said, well, that's really not part of pre-voc services, so don't mention that in your documentation. That's not okay. If it's not part of the services, you can't bill for the time you're providing whatever you're providing to pre-voc services. So anytime you're billing a service, you need to be providing that service. This is just a listing of where you can find the scope of services. They're all in Chapter 78 for each one of the waivers and habilitation services. Again, it's very important that all of the people providing the service understand this. For instance, one of the things that we run into our agency often is that we serve both people in home-based habilitation services and folks who receive ID waiver services. In ID waiver services, it's possible to transport someone to and from their day service. That is not a component of home-based habilitation services. So it's important that people not only understand what the service is, they understand what service they are providing when they're providing it.
We just had a question come in. It's a great question. That is, must the documentation be in a narrative format? And this is actually something that we've been talking about a lot as of late. And the answer is that for most services, yes, there must be a narrative component to that documentation. This is the way that Iowa has decided to implement documentation for many of the services under kind of that HCBS umbrella. There are some services that might have less of what we would consider a narrative component. For example, CDAC services utilizing the CDAC documentation form would definitely look like it would have less narrative than something if you were perhaps documenting for ID waiver SCL, for example. Thank you for that question.
Maintaining records. Obviously, you need to maintain records to support what you build. So every unit you build, you need a record for. And you need to support the determination of your reimbursement rate. So you need both of those records. So things like your cost reports you need to keep, or how you arrived at your fee-for-service rates, you need to be able to show. And then obviously you need to show that each unit you build for is tied to an actual service that is documented. As far as maintaining records, if you look at Chapter 79, 3.3, Parent 3, it will give you those requirements. And if you give me a second here to scroll down, I'm actually going to read those to you. It says the provider shall maintain records as required by this rule during the time the member is receiving services from the provider for a minimum of 5 years from the date when a claim for the service was submitted to the Medical Assistance Program for payment, and as may be required by any licensing authority or accrediting body associated with determining the provider's qualifications. So you're going to keep service documentation for sure for 5 years past the time that you build that service. It is possible for, if you are reviewed, they can go back up to 5 years and request your service documentation. Those of you who have had an HCBS review, which is most of us, one of the things they always ask for is documentation that is more than 5 years old. They want to see that you are actually keeping documentation based on this rule. Medical records, clinical records must be complete and legible. So if you're handwriting your documentation, you need to make sure that you can read it, and there must be a record for each service for which a charge is made. I'm kind of beating that one to death, but that is critical that you are confident before you bill something that you have documentation that supports the amount of units you are billing. Medical records have to provide evidence that the service provided was medically necessary. As we move into managed care, this is going to be as critical or more critical than it's ever been. So that means the services you're providing need to be tied to an assessed need. That's not a new rule, that's always been there. That's what your service plan should do. It should describe why those services are necessary. It should be consistent with the person's diagnosis, and it should be professionally recognized as a standard of care. So as we move into managed care, I think when I look at the provider manuals, they all speak to needing that medical necessity and being able to show that when a service is provided. The service record must include the medical assistance or Medicaid number, the date of birth of the member, and the reason the service is medically necessary, and the level of care associated with the service. So it's going to tell you how many, if the person needs IDSCL services, how often do they need those services? Why do they need those services? What's the reason that they need those services? And that should all be documented in the case manager's plan. And at least the case managers we work with are pretty good at that. But it's always good to review that so you're clear that all the person's needs are actually listed in the service plan. Occasionally you'll get a service plan where something you see as critical to that person's well-being for whatever reason didn't make it in the service plan, and then it's important to work with your case manager to assure that that gets in the service plan. Now we're going to kind of switch and go to the components of the service record. Each page of the documentation needs to include the first and last name of the member. If you're using electronic documentation, their first and last name has to appear on each screen when you view it electronically, and on each page when it's printed. When you're reviewed, at least when we've reviewed, auditors are very willing to simply look at the computer. They're not requiring us to print all the documentation. So the basis for service must be identified in the items below: the member's medical or social history, the goals identified in the member's plan, in some cases physician orders or any prior authorization required by Medicaid, and related professional consultation reports. So we just need to make sure that we have those for each person. You're going to want your record to include the progress or status notes of the service, all forms required by the department as far as the condition of payment. So in most in HCBS services, typically that is the service plan that's required, as well as progress notes.
We've had a couple of questions. One that relates directly to what Lisa was just talking about was having the name on the documentation. And so this question is, if the documentation is on the front and the back of the same page, do you also need the member information on the flip side? And it is our understanding that yes, you do need to do that. Part of the reason that you need that is because if you end up having to send this information in, and it comes out on like single file fax forms or something, they need to be able to be sure that that information is with that individual. And that really is for your organizational benefit as well. I mean, especially when you're talking about documentation, if you didn't have that, that could be the difference between having to pay back money and not.
So if you're using electronic documentation, almost all electronic systems have that. If it's paper documentation, I would encourage you just to print a header on each sheet so that that's always there. So in addition to services being...
I had a question if you could repeat the last part. Wait, Donna, I'm not sure if you were talking just about the assessment information, or if you could maybe give us a little bit more on what you didn't catch there. We can go back to that. And then we have one more question that's about the date of birth. And this is specifically, it says, I thought the date of birth was removed as a requirement on service records. I think what you're thinking about is that for a period of time, the date of birth was required, and they asked that to be on both sides, on each page of the documentation. What Lisa's talking about here is a part of the overall service record, which is kind of the broader scope, right, of what that person's, I don't know, at the agency where I used to work, we used to call it their main file. I mean, it was, and so all of this stuff has to be in the main file. You do need to have them identified individually on each page, but the requirements for that were loosened slightly after that first came out.
So what you need on each page is the member's full name. Somewhere in the record, you need that their name associated with both their Title 19 Medicaid number and their date of birth. But you do not need the Medicaid number and the date of birth on each page of the record.
And it also might be worth kind of belaboring the point that it needs to be their full name as identified on their Medicaid card. So if my name is Michael, but everybody calls me Mike, it's not enough to say Mike Nelson. You need to identify it. And some people will then say Michael Nelson, AKA, or have something so that it's clear that they go by a common nickname, but you must have that match their Medicaid card.
Do we have clarification on that question? So in addition to the service being within the scope of services, all services must be authorized in the person-centered plan or the CDAC agreement, which includes the goals the person is working on and the supports that they need. If something is not in the service plan, but it's in the scope of service, you still cannot bill for that service. If in the course of providing services to the person a new need is identified, prior to billing for that or prior to providing that service, you need to get that added to their service plan. So, it's important that staff are not only trained on the scope of service, but they're trained on each person's service plan so that they know when they're working with a person what services that they need to provide to that person. Then the required components of the actual service documentation, and these are from Iowa Administrative Code 79.3 Parent 2. C3. So if you want to go read that for yourself, that's where you find it. You need the full name of the member, and as Britta explained, that is their name as it appears on their Medicaid card. You certainly can put aliases in there, and as you're doing the documentation, refer to the nickname or the alias, as long as it's indicated by that person's name that that's the nickname they go by. You need the specific location, and they really do mean specific location. So if you're providing services to someone in their home, you certainly can say, you provided those services in the person's home. If you're providing the service somewhere out in the community, you need to identify that location. If there's more than one location in your community, so there's 2 Subways stores in your community, you need to say which Subway they went to. There's a lot of discussion amongst various agencies as far as, do you need the full address? Do you not need the full address? We do not believe you need the full address. What I always say when I'm teaching this course, though, is if your supervisor wants something, you always have to listen to your supervisor. So you do need the specific location so that whoever is auditing it could say, yes, I know this service took place at this location.
And we had a question come in asking, does this mean every location that you visited during that shift? And the answer to that is yes. So if you provided services to me, and if you're in this example, let's say I'm receiving daily ID waiver services, and you take me to 15 places because we're running a lot of errands, then yeah, you would need to articulate that. And what we have heard past Medicaid auditors say is that they need to be able to track that back to a specific piece of land, a specific tract of land. So like Lisa said, if there's only one subway, you might be safe saying subway in Cresco, Iowa. But if there are multiple, then you need to boil that down at least to the street or something that's more precisely identifying.
You also need the complete date of the service, so month, date, year. For those of you who use electronic documentation, most electronic systems will default to the day that you're putting the documentation in. So if for some reason you're documenting the service on a date that it wasn't provided, you need to make sure that that date is correct to the date you actually provided the service, not the time you're documenting the service. You need start times, end times, shift times. So in services that are provided on a less than a daily basis, you need start times, end times. AM and PMs are very important. If you're providing day habilitation services from 9 a.m. until 11:30 a.m. is much different than if it's 9:30 a.m. to 11:30 p.m. So you just need to make sure that you have those times in. If you're providing services on a 24-hour basis, you're going to have your shift times in there. So whenever your shift starts to whenever it ends.
Related to shift times on documentation, we have a question that is specific to transportation. And the question is, can you bill for the time that you're transporting or person's being transported to and from medical appointments if you are not that non-emergency medical transportation provider? So it's a pretty detailed question. And it is our understanding that the time that a person is being transported is billable, assuming that their assessment and their service plan indicate that that person needs that support and supervision during the transportation process. If that person is able every other day of the week to go all over town without support and supervision, you would have a very difficult time justifying billing for that time in that circumstance. Another question is, can you use military time instead of AM and PM? It is my specific understanding based on our organization's experience during a Medicaid audit that no, you cannot and should not, because then the auditor doesn't know for sure that 8 to 9 or whatever is actually 8 to 9 a.m. Just use AM and PM. It is definitely the safest, and that is feedback that I received personally in a Medicaid audit. Great idea. I thought. All right, I'm going to turn it back over to Lisa.
So you also need your staff signature and staff credentials, if any. So a staff credential would be like an RN is a staff credential. There was a time where it was required that you have the person's title in the documentation. That was changed, I think, back in 2007, but I know that that's a question that comes up still routinely. There's no requirement that you need the person's job title, but if there is a specific credential, that should be on there. The other thing that you need is specific interventions. So specific interventions is what you do to both support that person and or implement the goals and objectives in their service plan. So all of your documentation should have specific interventions. Then along with that, you of course have the member's response to those interventions. So if you're supporting a person getting up and ready for their day, your specific staff interventions would be whatever you did to assist them in doing that, and the response would be how they responded. It could be that they got up. Same with other services. Some services such as pre-voc is very narrow. So everything you do in pre-voc is going to be intervention specific to that person's pre-vocational goal. So if their goal is to stay on task, your specific interventions are going to be around supporting them and teaching them how to stay on task while they're working. You also need the member's progress. Sometimes that's in progress notes, but from reading your documentation, you should be able to tell that was this person successful in meeting the steps of their goal that particular time frame, or were they not? You need supplies dispensed. So if you're billing any supplies to Medicaid, you need documentation that those supplies were dispensed to that person. If you're administering medications, you need the name, dosage, route of dispensed meds. Typically, that is all recorded on the MAR. So there's not a need for you to write in your narrative documentation the name, dosage, and routes of each medication. It is fine to say, I administered Brita's morning meds. You can say administrator too. It just sounds weird. So, and then obviously you need documentation for each shift for a daily service. In the agency where I work, one of our top 5 errors every year is that we don't have documentation for each shift on a daily service. I think there's several reasons for that. One is very simple, that sometimes our electronic system doesn't work and people hit save and it doesn't save. Sometimes it's just that, you're doing your documentation after you've worked a shift and you really believed you documented on all 4 people that you were supporting, but you only documented on 3. One of the easy way to assure that you have that is just assign that task to probably an overnight person, so that each day when they come in, they check the documentation of the previous day to make sure that there's documentation for each shift, and then leave a note if there's not. You're going to want to assure that your documentation includes changes in the person's health. That's very important. If someone has a huge medical need, hopefully by documenting changes in their health, you'll be able to catch that need soon rather than later, and that's going to lead to a better outcome for that person. You're going to want to include any unusual behavior the person has, because typically, especially when working with folks with intellectual disabilities, they tend not to be good self-reporters. So sometimes the only way you know that something's wrong is that they're behaving differently than they typically behave. So it's very important to document that so you can see if that's a trend or if that just happened to be an anomaly for that day. You want to make sure that your documentation is descriptive versus opinion. So opinions are people were happy, people were sad, people were crabby. Those are all opinions. You want to describe what led you to the conclusion that that person was sad, or what led you to the conclusion that that person was crabby. You always want to make sure that your documentation supports the time billed, whether that's okay, I just lost my train of thought.
Supporting the time billed. So you need to be sure that if Joe Public were to read the documentation, which of course they wouldn't because of HIPAA rules, but if they were, they would be able to say, yeah, like I get how what you have written here could take X amount of time that you had billed for that person, whatever the service might be.
This has been one of the areas when we meet with the surveyors that they say that really causes people a lot of difficulty, that they'll go back and it looks as if things are, I don't want to say padded, but based on the amount of time, but it really raises red flags. So that goes back to making sure that you put all the places that you went with somebody, that you were very accurate in what exactly you did. And have all of it there instead of just making some blanket statements about the generals that you happen to do with that person.
And this goes to one of the questions that have come in, which is, are you saying that what you need in the narrative is like a diary entry of supports? And that's not necessarily it. It doesn't need to be necessarily that staff are just listing the 1,001 things that they do within a day. But rather you need to have documentation that is consistent with the service plan and the assessed need, and really shows what intervention you provided as a staff person. So why are we getting paid to do this? But also, what was that person's response? And so we can get to that idea of, is a person progressing, or are there some places where they might be regressing in their skill level or in their state of health?
And where this is going to be looked at the most closely isn't in daily services, but tends to be in services that are billed on an hourly basis or a 15-minute unit. So if you're providing pre-voc services, for example, you need to show that throughout the time period that you billed pre-voc services, you were interacting with that person around their service plan. In SCL services that you're providing on a 15-minute unit, you need to show that you implemented the services as described in their service plan, and it made sense that it would take that long. So that's where locations are important. Mm-hmm. And you need enough detail to say, yes, it would be reasonable that it would take someone that long to support the person in doing their shopping, setting up their medication, cleaning their apartment, whatever that service might be.
We have another question come in that is asking if there is a certain time limit that people should be meeting with folks. And the answer is no, not necessarily. I'm assuming that we're talking about what we would used to call hourly services, or something that's being billed on a 15-minute unit. And I don't know of anything from a state level that has ever come out that says, like, this is the hard deadline. So I do know of a number of organizations who, within children's SCL services, have made the individual agency policy or practice decision that, you know what, SCL shouldn't, at least for us as an agency, go beyond 60 minutes, 90 minutes, 120, based on whatever that service plan says, because of kind of the individual intricacies of that children's SCL and the need for that to be a skill-based service encounter.
So there also are obviously services are billed on a 15-minute unit. Those units are rounded after 8 minutes. So you as an agency need to determine what works and what doesn't work for you. But there's no rule that says you have to provide X amount of service in an encounter outside of that. Your documentation has to show implementation of the service plan. So if the service plan states that it's the goal of the person that they exercise for 30 minutes 3 times a week, you need to show in your documentation that you encourage that person, whatever their service plan says, to actually exercise at least 3 times a week. Now, you know what? If the person chooses not to do that, that's what you document, but there needs to be documentation that shows you were working on that goal and you were encouraging that person based on their service plan to do that. And you need to assure your documentation supports person-centered planning. And a lot of that is just the tone in which the documentation is written. If you're reading documentation and your thought of the documentation is the staff is in charge and they're directing this person's life, it's probably not person-centered. So your documentation should show that you're inquiring about to that person as far as what they want. You're supporting them in the manner that they choose, rather than in a manner that you believe is best for them or that fits the best with your schedule. You always have to prove it. You need to prove safety and support. You need to substantiate, assess needs, and person-centered plan. And you need to show that intervention was provided as needed. So all of those things are things that if you're audited, the auditor will be looking for. We have developed a few kind of cheat sheets for you, and you should be able to print these, right, Brita?
Yeah, and if anybody has any issues with downloading them, please feel free to email me at bnelson@iowaproviders.org, and I'm happy to email them to you. If you are viewing the live webinar right now, in your GoToMeeting control panel, there is a section that is called handouts. And if you expand that, you should see both the PowerPoint slide deck as well as these 4 handout examples. And when you click on it, it might not actually show up. It might go straight to your downloads folder. So you want to search there and open it from there.
So I'm just going to go briefly over the one that's entitled HCBS SEL 15-minute unit and HBH tiers U4 through U6 documentation. So there's just 4 sections on there. It's recording time, support documentation, goal documentation, and general things. How we use these in our agency is we hand them out to staff. We encourage them to put them where they can access them when they're documenting. It's a great tool for orientating staff and just, goes over several things. So like in this one, under support documentation, it says no supervision can be provided to children 17 and under. Services must develop adaptive behavior or health skills. Just so that people know that when they're providing SEL services to children, supervision cannot be a component of that service. All of it has to be directed to their skill. So these are 4 that we developed, and it's really intended to be kind of a template for everyone that you can develop similar documents for your agency. Excuse me. So, excuse me. So now we're just going to go over some documentation examples. And this is a pre-voc example. So the scope of services for pre-voc, it teaches general work skills, not job-specific tasks. So if this is on Brita, and I can vouch that Brita really does need this as part of her plan. So her goal is to stay focused on her task. So the documentation is 9 a.m. to 11:30 a.m. When Brita arrived for work, I encouraged her to stay focused as needed to do her new job today. I showed Brita the 3 steps that she needed to use to wipe the tables and then asked her to do one. She forgot to use the sanitizer spray, so I corrected her and reminded her to wipe the entire surface. This is all very job specific, so it would not fit the scope of the service, nor is it authorized in Brita's plan. So if that's what your documentation looked like, you would not be able to bill pre-voc services for 9 to 11:30 a.m. that day. If you turn it around and say, well, washing tables, Brita frequently stopped to chat with people as they walked by. Each time I reminded her to refocus on her task, and each time she responded by saying sorry and returned to washing tables. That is not job specific. It's within the scope of services, and it's authorized in Brita's plan, so it is billable as pre-voc services.
So the next example is with hourly SCL. And we've got the scope and what the specific plan says there. So Gayla's going to be setting up her medication planner with support, and she's going to be maintaining her home with support. The documentation articulates that Gayla asked staff if they could take her Christmas shopping to pick up a gift for her mom. Staff provided transportation. They picked out some gifts. Gayla picked out some slippers and a bathrobe for her mom. Now, while these are within the scope of services potentially, they are not authorized in Gayla's plan and could not be billed. So this is an example where what is allowed under the greater umbrella of services might not be okay for an individual person if that is inconsistent with their assessed needs and with what their interdisciplinary team has approved within their service plan.
So this is an example of what would work for Gayla, and the documentation says staff asked Gayla what she would like to do. Now, even though Gayla said she really didn't want to do anything, of course you can still bill because you're in there encouraging her to do something. And then they helped her set up her medications and coached her through that. So that would be a billable service. Here's a link to CDAC documentation. So you can click on that and it will take you to the CDAC training video and give you more specifics if you're providing CDAC. So,
Lisa, here's a question. On the pre-voc example, it shows that it rounds down if the hours are below 30 minutes. Oops. And this was not our understanding for hourly billing and pre-voc. Is this in the code? To go,
can you read that question again?
it shows that the pre-voc rounds down if the hours are below 30 minutes. This wasn't their understanding for hourly billing and pre-voc. Is that in the code?
I actually do believe that is in code. It is way at the end of chapter 78. In chapter 78.41, the last sections speak to the rounding rules for all waiver services. And I believe you at 1 hour and 30 minutes, you would round down. At 1:31, you would round up. So, Britta, you want to see if you can find that code?
Absolutely. I'm going to look that up while we keep on plugging. All right.
So the next section we're going to talk about a little bit is Medicaid fraud. We're going to be doing a lot more of this in our April training, but it's important for all staff to know that if in their documentation, they write something down that did not happen, or you're billing for services that you know you do not have documentation for, that is considered fraud. So knowingly making or submitting false claims to the federal government. As providers, we're responsible to submit accurate claims and to maintain accurate records to support those claims. So it's just not something you ever want to do.
Hence the picture of the person in the orange jumpsuit.
Yeah, because unless you look really good in orange, you don't want to do that because you could go to jail and you'll be wearing orange. So if you need to make changes, corrections must be made by the person who provided the service or someone who has firsthand knowledge. And firsthand knowledge means they were there and saw the service being provided. It doesn't mean that someone called you and said, hey, you know what, I messed up that documentation. This is what I forgot to put in. Could you put that in for me? You actually have to have seen that service. A correction must not be written over, otherwise obliterate the original entry. So if you're writing out your documentation, you would draw a line through what you are correcting. You would date it and sign it. If it's electronic documentation, there needs to be a mechanism in your electronic system that saves that documentation and then shows who changed it and what date it was changed. If a correction is made after a claim's been submitted and it affects the amount of time that you billed for the claim or the accuracy of that claim, then you need to submit an amended claim. Other things to remember is you always need to be respectful to the people you're supporting. Remember, it's your job to walk alongside the person to support them in reaching their goals. One of the ways, a good test of that is, would I be willing to read this back to the person I'm supporting and their family? If you're not, you probably don't want to write that in. One of the things that I look for in documentation, very rarely do I see someone being disrespectful or being mean to the person. What I tend to see that's disrespectful is they're writing as if they're writing about a child when the person they are supporting is 42 years old. So, if you're reading the documentation and it appears that you are the person was working with a child, that's not respectful. We need to respect the person's age as well. Cutting and pasting from one day to the next or from one person to the next is never acceptable. That will always be seen as potential fraud and as a major performance issue. Don't do it. I can't say that more clearly. Documentation can only be completed after the service has been provided. You wouldn't think that you would have to say that, but it's important that people get that even though every morning is exactly the same for supporting Brita and getting up and ready for her day, you can't complete that documentation for Brita from 6 a.m. until 8 a.m. when she leaves for work at 5:30 a.m. when you actually have time to do that. You have to complete it after you've actually provided the service. Just some things we kind of wanted to go over is compliance with the MCOs is not going away. You're still going to need to do your remediation, discovery, remediation, and improvement. You're going to have to show that you're checking on people's, that you're checking your documentation, that you have what you need in the person's file. All of those things aren't changing. So, kind of a summary is provide services according to the plan and be sure your documentation justifies the time that you build. If you have those two things taken care of, you shouldn't have any issues with that. Rita is still looking for the rounding rules.
Sure. And so what I have found in 7841 parent 1-3, it indicates that for pre-vocational services, a unit of service is a full day, which is 4 to 8 hours, or a half day, which is 1 to 4 hours or an hour. This is what it says. Now, there's also a FAQ from a series of presentations that were done by the department and some questions that we submitted from IACP. And there's the obvious question of like, well, what if it's like, 4.01? And the direction that they gave with that FAQ was that 4.25 hours would be when you would round up. We've got some other questions that have come in, and this might be a good time to get to some of those. This one, great question. Can a supervisor correct something unrelated to the actual services provided, such as the billable time? I think that this would be a really risky practice because the billable time is actually one of the kind of most important pieces of that service unit and what you are billing. And you might be able to make a case for it if that supervisor was physically present and observing that service. But outside of that, I would say no. It needs to be the person that wrote that documentation that is making that change. We had another question that was specific to billing for habilitation services. And these people, this question had heard that IME was no longer, and that we were no longer going to be billing tiers for home-based habilitation. That comment, I think, was made at a couple of statewide trainings, but is not the case. You will be billing for habilitation as you were billing under Magellan. So if you heard that, we heard that too, but have since clarified that information with people at the Department of Human Services, and they let us know that that was not the case.
The reason they answered it that way at several of the trainings is that the tiers had not been posted to the fee schedule, and it referenced, their training referenced the fee schedule that was posted in code in rule, and they hadn't gotten those actual numbers posted for us. Now they're there, so it's consistent with what they were training. It's just that the tiers had not been listed previously to that.
Right. Now, here's another really good question. So let's say that you're working providing daily services and you're working an overnight from 11 p.m. to 7 a.m. Do you need two separate logs, one from 11 to 11:59 and one from 12 a.m. to 7 a.m.? The questioner says that they've heard that both ways are okay. And I think that the most conservative would be to make sure that you can somehow within your documentation, whether that's on paper or through your system, articulate both things. So which day is the 11 to 11:59, and then the next day, which is the 12 to 7 a.m. I know the documentation system that we utilized at the organization where I used to work would have you enter this as two separate logs. So when we did paper documentation, we just articulated it in writing, and that was a pretty quick way to do it as well. It just needs to be clear. Let's see. For those of you that are asking questions regarding specific billing codes, this is something that I think I'm going to try to get back to you on within the next couple of days after the webinar is over. The next question is regarding daily services. Can documentation be started after a person in services goes to bed and is sleeping, or must you wait until your relief staff has taken over? The process for documenting within daily services in the way that you're talking about is often an agency-specific practice. Within hourly services, it is super clear. Documentation time is not part of that. That is after. And we have routinely maintained that it makes little sense to incur extra and unnecessary cost when the person that you're serving is sleeping if you could be documenting at that time rather than doing it during alternate time.
Be careful, though, that you are not documenting as if the entire shift is over. That you are only documenting and adding documentation up to what you truly know. Back to Lisa's point, we can't be the great Kreskin and know that the person is going to successfully sleep all night or whatever, but it needs to be, you can put down what has already transpired, but you can't project to the end of the shift.
Okay. This is Lisa. Chapter 78.4.1, Parent 16 has general service standards, and it talks about how you would round a 15-minute unit. It also says services must be billed in whole units, which gets back to the needing to be very clear when one day ends and another day starts in your service documentation. But it says for all services with a 15-minute unit of service, the following rounding process will apply. Add together the minutes spent on all billable activities during a calendar day for a daily total. For each day, divide the total minutes spent on a billable activities by 15 to determine the number of full 15-minute units in the day. Round the remainder using these guidelines. Round 1 to 7 minutes down to 0. Round 8 to 14 minutes up to 1 unit. So that doesn't give you the half hour, but that gives you the 15 minutes. So we will continue to look at that half hour one and get that out to you.
I have another question here. It's on signatures. So the question is, if a staff person is signing a document with their initials, so if I was signing it B. Nelson, can you do it that way, or do I need to sign it Brita Nelson? It was always our practice at the organization where I worked that signatures actually meant write your name legibly if you were signing a piece of paper documentation. We would recommend that you have people sign it with their full first and last name. And not only that, but they do it in a fashion that it is legible. I know that my actual signature, the one I sign at the grocery store on the card machine, is not something that anyone could read. That's not the same signature that I would utilize if I was billing or writing Medicaid documentation. Thanks for the question. It looks like we are coming up on 5 o'clock, and our build time was from 425. So for those of you whose questions we have not gotten to, we are going to do our best to get back to you electronically because you guys have a lot of great questions that have come in. We sincerely appreciate all of your participation within this presentation today and hope that you'll join us in April for our regional TA training. Anything else to add from Lisa or Gayla? No? All right, beautiful. Thank you, everybody, for joining us, and we hope to see you in April. Bye-bye.